Good morning, everybody. We are going to listen on the post-transplant MAFLD. So this is the outlines we are going to cover. So first of all, why we need to see the post-LT metabolic syndrome. You can see the NFLD is around 1/4. The transplant for the NFLD is going to rise. SCC is also coming up. So whenever the case of NFLD you are getting, so there is by 2030 you will get another 168% increase in decompensated cirrhosis, increase in 170% liver related death, and 137% incidental SCC detection is going to rise. So how the transplant long-term outcome differs? You can see the first year mortality is the maximum. After 1 year only 20% mortality happens. If you think of the first year after long-term mortality, first 2 to 5 years, the causes are malignancy, liver-related causes, infection, coronary disease, and multi-organ failures. As more than 5th year, it is malignancy versus coronary disease and uncommon infections. So they are the major causes. The liver is out after 5 years. So how a comorbidity is going to impact? You can see here there is overall temporal increase in the comorbidities associated with the transplant either before or after it is coming up. So this is an interesting concept. You can see here a person has developed a post-NFLD, post-transplant NFLD. The mortality is increased in long term by 2%. But however, this mortality is mostly due to cardiovascular events. So hence post-transplant NFLD is more worried as far as the cardiac concern than the liver itself or the rejections. So how and how frequent it is when you go for? So if you go for the post-transplant metabolic syndrome, you can see it happens from 45 to 60. Nearly half of the patients has to have the post-transplant metabolic syndrome, which includes obesity nearly half, hypertension close to 70%, triglyceride is close to 85%, low HDL in around 50%, and they develop de novo fatty liver is around 40 to 60. Nearly half will develop fatty liver because of the post-transplant. So how is the spectrum? You can see this is the way the things are happening. So etiology is NAS related or it is other related cirrhosis. They develop de novo. That means if they are not having any NFL related liver disease, and those who develop re-cirrhosis because of NFLD. And the mortality shows that close to recurrence has been seen in 82% and up to close to 7% have a de novo. And this is also progress in the similar pattern, steatosis, steatohepatitis, fibrosis, and they develop cirrhosis. And if the cirrhosis is happening, you can see the advanced fibrosis progression is faster, and now some studies to have the PNPLA3 has been associated with post-transplant NFLD fibrosis progressions. So what are the risk factors if you think of? It is pre, post, and donations. Here you can see the post-transplant BMI, presence of alcohol before and after transplant, development of dyslipidemia, all components of metabolic syndrome, presence of graft steatosis either before surgery or after the surgery developments, and related to immunosuppressions, and more significantly the steroids. So these are the common risk factors. When you group them to the risk factors, you can say recipient related, you can think of the lifestyle is the most common. They have pre-LT transport risk factors which are continuing, genetic or epigenetic factors, and the gut microbiota. And the donor related factors include the graft steatosis, or if the donor is predisposed to genetic factors, then these factors of the metabolic components get added on, and along with the immunosuppressions, they leads to the development of the progression of disease. So as we discussed, the genetic factors plays important role. You can see the recipient related are PNPLA3, HSD, SREBP1, SOD, and donor related are also PNP3, collagen 13A1, and FAB. And of these, if you think of a recurrence, it is SOD2 and HSD. These are the two significant factors coming up on the donor and recipient. Those recipients having adipose, they have a faster and more severe progression. So if you are getting the patients on post NFLD, both the donor and recipient genetic polymorphism is taken into account for the development as well as for the progression. Similarly, there is gut microbiota. It is interesting that the gut microbiota has get totally modulated after transplant. So we don't know whether this gut microbiota in a host is donor derived or recipient derived, which we thought of a thesis, but we are not able to complete that. That is interesting. But here they shows these are the bacteria present for the development of the MAFLD. So these are the bacteria for the development of the rejection episodes. So definitely, so bacteroids, fusobacter and streptococcus, these are the two common factors which are in the host leads to the development of accelerated MAFLD spectrums. So how this happens, we go to this, so this is a clumsy slide. I just want to say that there is multifactorial insulin resistance, lifestyles, immunosuppression, genetic predisposition that leads to the cascade of steatosis, ER stress, then oxidative stress, and this leads to the overall cascade damage in all the components of hepatocyte Kupffer cells, leading to the progression of fibrosis and steatosis. Then how we are going to address this? The most important strategy, I think, to be detect early. So how to go for? Post-transplantation syndrome is defined as any three of them: obesity, hypertension, diabetes, low HDL or raised triglyceride. So this is the ATP3 criteria has been used. So among these, this is a comparison of all the established metabolic syndrome parameters. However, there is no data on post-transplant metabolic syndrome, which is all metabolic syndrome characteristics which have been extrapolated to the transplanted patients. The fasting blood sugar, obesity, hypertension, triglyceride and HDL. Then if you thought of a screening test, the non-invasive tests are the way forward. So blood test, the commonly used. So you can think of APRI, FIB4, NFS, these are commonly used for the post-transplant, but problem for them is all includes platelet. So post-transplant, they will have a platelet as a confounder, and that is irrespective of the liver fibrosis. You are taking everolimus, antiproliferative drugs, so who have also impact on the platelet count, so we don't know how it is going to refill. So this is an area of unmet need. Then comes the ultrasound. It shows that it can be having sensitive good and specific good, but it only when the fat content is more than 20%. If it is below 20%, the sensitivity only 55%, and in presence of obesity, that has own complication. Then next comes is the MRE. MRE has been used, but the data is very limited. It is only for the graft fibrosis, and which has been extrapolated from the Hep C patients with advanced fibrosis. If a cutoff is getting 4.2 kilopascal, then there is likely chance of having a fibrosis, but not steatosis. So in MRPDF also there, but they have not published literature on how MRI detecting the steatosis percentage in post-transplant liver. Then the most commonly what used the fibroscan. So fibroscan has been studied in the various studies and shows a cutoff close to 238. So and a cap of severe to having more than 290, and fibrosis is more than 7.5, and to have a cirrhosis is around 12. So this is the studies based on various sample sizes and difference. But most important thing that in our scenario where we have a live donor transplant, in live donor, if you put the probe here, this is the area, either it will be blank or it will be bowel. So hence it is very difficult to get, and we have also get a good poor experience of getting a fibroscan post transplant. We have to put in the epigastrium. Sometimes we are not able to find the window. So these are the drawbacks of the fibroscan in a live donor setting, but there is no data on this, how the live donor setting fibroscan to be used as a non-invasive predictors for the outcome. Then you think of how to move forward. So to me, CK18 has been shown in one study only, 82% specificity and sensitivity, but we can combine clinical and genetic parameters. AI based models can be a future, and the another unmet need is how we can incorporate a post-transplant metabolic syndrome to detect it in a routine follow-up protocol. Because these follow-up protocols, how frequent to be done, what are the parameters to be done, and how you are going to do the immunotherapy, immunosuppressions to be customized is not properly known. So just to my suggestion is the most important is that ALT and ultrasound has a good accuracy for whom to suspect. Then you think of a fibroscan if possible, think of having a 238 cap, above is mild, more than 290 is severe. If you think of LSM, it is more than 7.9 or more than 12, you can think of a fibrosis or has progressed to the cirrhosis. And then if we are not able to detect the liver area because of the right lobe or the heavy livers, we can think of MRI elastography, and cutoff data is the more than 4 is suggestive of the fibrosis, more than 5.9 as cirrhosis can be thought of to go for. And the gold standard is of liver biopsy, but it's very difficult nowadays to go for a protocol biopsy or when to go for biopsy, or you can go for biopsy when you suspect. So it is cannot be part of routine protocol because now most of the centers discuss any protocol biopsy. So biopsy has a role only when you get a suspicion of having transaminitis or fibrosis only. So simplest we can think of clinical parameters, genetic models, and obviously ultrasound, fibroscan. So these four can go to do it, but we need to study our own data. So after the first needs to detection, the second is to treat the complications. As you know, the treatment is mostly the same, except the lifestyle will remain the same. You have to address the comorbidities. Only addition is the immunosuppressions, how to be monitored. We'll go subsequent slides. This is only three things we can think of to go for. And some show that olive oil with a Mediterranean diet has some benefits, coffee has some benefits, and omega-3 fatty acids. So these are the case report, last data, but without having any, so we cannot able to do this. Then concept pharmacotherapies. This is nearly the same as far as other fibrosis models what we are using, all combination of drugs. So it is not specific for this. If you think of addressing the obesity, it's very interesting. Any person who have a transplant, the obesity develop around 7% only in the first year, and those who are obese before, they will remain likely obese. And normal weight who has been transplanted, nearly 1/3 develop obesity. And there is multifactorial causes for this, and this is the timeline to show develop how they develop, and this is in the first year how they develop the obesity. In 1 year follow-up, gradually the obesity is increasing over the time. Then how to go is a very interesting concept. They have told that these people after transplant have a basic resting energy expenditure is low, and when they go for this we have to exercise max, also if it is MAFLD related, they have a expenditure of energy also on the lots. That means their expenditure at rest is also low. If they do for the exertion, they are relatively low exertion, so that's why they get a calorie reserve, which may lead to the obesity. Then diabetes. So diabetes in post-transplant is multifactorial. You can see donor, LT specific, procedure dependent, risk factors now coming up, and the classical risk factors as we know, BMI close. So we need to address all these things. Most important is to know that. Know that is defined as 2 post-transplant fasting plasma glucose more than 126, 30 days apart. If he is having requiring sugar control by a OHA for more than 30 days, insulin therapy requiring for 30 days, or HbA1c at single point of time 6.5. If you have any one, then he is having to a new onset diabetes after transplant. And know that is not only for the diabetes, it increases chance of rejections, and these are being frequently affected by the steroid pulse, cholesterol, and tacrolimus in the fasting the dose level. And if you think of this is interesting, so that in long term these patients are followed up. Those having NODAT, those having pre-existing diabetes, the poor outcome is with the NODAT. The survival is affected if they develop new onset diabetes during treatment, and hence it needs to be considered. And can we predict them? So this is a AI based model where they have taken these scores to get a good prediction and includes age, male gender, obesity, and sirolimus. And now I think sirolimus we are using very less. So this is have a big data on AI based to predict mortalities. So now this is an interesting slide for us for managing diabetes. Metformin we are preferred, but having not a good data. Sulfonylurea as known to long term to have some carcinogenic potential. These meglitine thiazolidines have not frequently used, so we have left the newer drugs, the DPP4, GLP-1 and SGLT2. Among these, SGLT2 is more promising in terms of both blood pressure, weight, it reduces the cardiovascular morbidity, and also prevents the kidney disease. So these 3 factors we can get medicinal benefit. SGLT2, GLP-1 is also having anti-inflammatory, anti-apoptotic, anti-immunomodulatory effect. So GLP-1 and SGLT2 are the preferred drug, and they are safe, having no drug interactions. So when you treat diabetes in a post-transplant, it's not the sugar. You have to see beyond. That is whether it is cardiovascular protective helping or no, it is helping fatty liver or no, or it is having obesity. So in this group, you combine these 3, you can see the common point for all 3 benefits is SGLT2 and GLP antagonist. And diabetic kidney disease, obesity, and cardiovascular disease are the things to be considered. So this is just approach I am not going to because of the limited time, but this is the similar way when you think of treating a post-transplant diabetes, we need the BMI, whether having steatosis or no, and renal disease. So three things have to see: obese and having steatosis and have a renal disease. Three things needs to be considered for formulating. And I want to tell that insulin is a good drug. Only thing that insulin has having long term to have a carcinogenic effect. One, two is injectable to be less preferred, and third is obesity. So these are the three things which think of to be on the good side. The dyslipidemia, it has been mostly the drugs related is corticosteroids, cyclosporine preferably than the tacrolimus, and all mTOR inhibitors, and it is further aggravated when give the dual regimen of cyclosporine with the everolimus. These two increase the significantly high level, and that needs to be considered along with the therapy. And statins and omega-3 fatty acids are least help. If you think of a major cardiovascular events, that is more risk factor, and the whole concern of this session is today. If you immediate post LT, the cardiac events are to be considered arrhythmia, heart failure, myocardial infarction, cardiac arrest, and this is predicted by a high MELD score, respiratory failure, surgical causes, renal dysfunction, a prior having cardiovascular disease or cirrhotic cardiomyopathy. So this is predicts to be developing in first month of any cardiovascular events. If it is in the first 90 days, it is arrhythmia, heart failure, myocardial and the cerebrovascular accidents. And this is the presence of renal dysfunction, pre-transplant cardiac disease, diagnosis of NAS, advanced age and male gender. If you think of a long term, that is 1 year or more, the mostly it is a coronary disease, cerebrovascular disease, arrhythmia or CAD. And this is also depends upon the age, male gender, smoking, dyslipidemia, the traditional risk factors, pre-transplant, cirrhotic cardiomyopathy, and also renal dysfunction, immunosuppression. They come into effect. So when we are thinking of, we need these are the risk factors are there. So how to go for? The simplest formula here you can see: if a person is having metabolic syndrome of any component, if he has a kidney disease, or he has end-stage kidney disease and smoking. So these are the four parameters that predicts the maximum chance of to have a patient who may have some cardiovascular event in post-transplant. So this is the interesting that importance of the hypertension. If BP is controlled, the mortality is on the 28% is got reduced. If hypertension is high, the mortality is 46%. So simply parameter of hypertension is going to be a poor outcome. Similarly, interesting parameters what we should forget in our protocol is the QT interval. If QT interval is a very simplest, non-cost effective, if you have measured it 48 more than 48 milliseconds is there, then we should keep a mark that he should be under regular cardiological screening follow-up, because this is one of the parameters that predicts the most of cardiovascular events after transplant also, either early in the long term. So this is very simplest to think of and can formulate the risk factors, QTC and pre-transplant factors. These three can categorize them to this. So consider this is the score that is most validated is the CROLT score. They have taken age, gender, race. So these are the parameters. The points has been given, and then this is only validated tool with a score of 13 to 15, 16 to 30, 13 to 36, 13 to 40. So this predicts that these people are going to have a high risk of cardiovascular events, and this is also available online. You can put this data to get the parameters and you can get the score calculated, and that case you can write in your OPD follow-up if this patient is having a high risk group or you want to stratify them. Similarly, the AI prediction model has come up with this. They have shown that in 4 years follow-up, the predictivity is up to 71%. Is not a good model, but the parameters is very important, that the age of transplant, presence of diabetes, creatinine, or it is cause for the cirrhosis, and hemodynamic parameters before the transplant. So these are the parameters which can predict to have a post-transplant cardiovascular events. So this is recently little bit advanced on the deep learning methods, where they have shown that the parameters to be taken for this is simple parameters. If they have a shortness with renal disease, hypertension, having liver failure unknown cause. So these are being 12 parameters has been taken, and this model is close to 84% for predicting a cardiovascular event. So these are the parameters you can put in the model to develop a score for these patients and more. And next important is the immunosuppressions. If you think of post-transplant metabolic syndrome, the each immunosuppression has different parameter wise prone through the side effects. Obesity, most is the corticosteroids. D1C diabetes, as we discussed, it is the steroids. So long-term steroid after 3 months is only selected case-to-case basis. and hence we have to decide on our protocols how to go for early steroid withdrawal. Then if with the dyslipidemia, cyclosporine and mTOR, I think the cyclosporine are very less often used, but we are using everolimus and we are getting also frequently dyslipidemias. And hypertension, think of it is the CNIs, tacrolimus, cyclosporine are the side effects. So whenever addressing post-transplant immunosuppressions, these are things to be taken into account if the patient is having a group of PTNS. So we need completely the clinical evaluation of the BMI, comorbidity and the medicines is going on. His considered steroids should be single morning dose and try to taper as well as possible. CNI tag already we are preparing over the CSA, and we should consider tag level as required to be considered, and also lipid profile. So these are the few approaches on the immunosuppression modification as long as post-transplant metabolic syndrome is concerned. So just to summarize my last slide, insulin resistance, we need to consider the steroid as well as possible. CNI to be minimized, cyclosporine can be considered depending because more resistance is with tacrolimus, antibiotic mTOR inhibitors to be considered, and as we discussed, SGLT2 inhibitors, and now few study comes only once it comes saraglitazar as the one of the good drugs. If you think of obesity, we know pharmacotherapy is not yet preferred. We have not gone into the variety procedures. Then statins, as we have discussed, and hypertension and diet and smoking are the factors. So what we discussed in few minutes, we think to know that natural history of both recurrent de novo MAFLD in our patients, particularly as far as MAFLD deficiency is concerned. What is the best non-invasive modality for the screening and diagnosis? How we can assess the safety and efficacy of weight loss pharmacotherapies or consider metabolic endoscopy as we are doing for the gastric balloon for the post-transplant patients, or bariatric surgery should be considered on the follow-up, that is its area. Then is there any difference, because pathophysiological mechanism is a little bit different as far as the recurrent or the de novo pharmacotherapies NAS is concerned, is any difference? And we have to formulate a screening guideline, what should be the protocol in this area, and we need a protocolized tailored immunosuppression strategy for these patients. So to me, we need to discuss host and patient predisposition, whether it is demographic, genetic or microbiology associated, the graft, steatosis, disease and the risk factors. Think of, is the NASH injury immunopathology spectrum progression, these areas totally untouched areas. Pathophysiology, how to consider the visceral or muscle fat, because we see the sarcopenic obesity, whether which is contributing more to this group of patients to this. So this I want to conclude my thought. Thank you.